Our presentation today focused on congenital sensorineural hearing loss. My name is Breanne.
My name is Melissa.
And my name is Jennifer.
So the first thing we should talk about is what is hearing loss. So defined by Mahoney in McGill's Medical Guide Online, basically states loss of sensitivity to sound as a result of disease, infection, injury, noise, or aging. But to kind of get a better understanding of hearing loss, which is essentially breakdowns in different components of the ear, you kind of really need to get an understanding of the anatomy. A lot of us have already taken our audiology classes as we're nearing the end, but just to have a brief overview. The first thing we're going to talk about is the anatomy. So there are three main components that make up the ear, which are the outer, middle, and inner ears. So first, the outer ear. This is the part that's the most visible, but it's the least important compared to the other structures of the ear. So the first thing we'll talk about is the function of it. So that collects and transports the sound waves to the middle ear. Some important structures you'll find here are the pinna and the external auditory canal. Next is the middle ear. So that is a small air-filled cavity responsible for changing sound waves into mechanical vibration. So some important structures you're going to find here is the tympanic membrane, which is also known as the eardrum. You'll find the ossicles as well, which include the malleus, incus, and stapes. And then you also have the eustachian tube. And lastly, this is kind of one of the most important parts of the ear along with the middle ear. We have the inner ear. This is basically what houses your sensory organs for hearing and balance. This is going to convert mechanical energy from the middle ear into nerve impulses that are sent to the brain via the auditory nerve. The 8th cranial nerve is also known as. Some important structures are the cochlea, semicircular canals, and the 8th cranial nerve. Now that we have a better understanding of the anatomy and we have that quick review, we'll talk about according to ASHA, there are 3 categories of hearing loss. ASHA, if not known, is the American Speech Language Hearing Association. There are 3 categories we look at to describe this hearing loss. The first one is known as the type of hearing loss. So this is categorized by, like I said earlier, where the breakdown occurs within the ear. This is kind of the one that's most common to people in figuring out hearing loss. There's sensorineural hearing loss, which is basically the breakdown is occurring in your inner ear, or it could also occur in the auditory pathway to the brain. There's many different areas within the inner ear and the pathway that it can occur. There's also conductive hearing loss, and it's a breakdown of either the middle ear or the outer ear. It could be one or the other, or even both. And then lastly, we have a mixed hearing loss, and that's going to be a combination of the sensorineural hearing loss and the conductive hearing loss. So an example of this could be you have the sensorineural hearing loss, the inner hair cells in your cochlea just aren't functioning right anymore at this point, and then you have impacted cerumen. So you started off with the sensorineural hearing loss, and then you just packed in the earwax, and now you kind of have a mixed hearing loss, but luckily the conductive hearing loss is something that can be reverted, whereas the sensorineural hearing loss cannot. The next one is going to be the degree of hearing loss. This is determined by the severity of the hearing loss that you do have. This is measured in decibels. When you see it notated, it's going to be a small d, big D, and then a big HL. So there are multiple categories of the degree. So the first one's going to be normal. This is 10 to 25 decibels of hearing loss. Sometimes you'll see slightly mild. This is more for children. It's going to be 16 to 25 since they should have better hearing than adults, so their range is going to be a little more focused. Next you'll have mild, which is 26 to 40 decibels hearing loss. After that you have moderate, which is 41 to 55 decibels hearing loss. Next is moderately severe, which is 56 to 70 decibels hearing loss. Severe, 71 to 90 decibels hearing loss, and lastly, the largest category is profound, which is 91 plus decibels hearing loss. So at this point, most of your hearing is gone. Some things they say you might hear are airplanes, things that are extremely loud to the average person. And last is the configuration of hearing loss. This one, I got the definition from ASHA because I felt it described it the best. The configuration, or essentially the shape of your hearing loss, is going to refer to the degree and pattern of it across frequencies or tones, as illustrated in a graph called the audiogram, and that's essentially a graph that audiologists read to determine your type and the degree.
Alright, so there's two main types of hearing loss that you can have, congenital versus acquired. And congenital hearing loss is present at birth, which is caused by mostly genetic syndromes. And then there's acquired hearing loss that could develop later in life, such as presbycusis, which is just general getting older, or Meniere's disease, which is fluid in the ear. So some types of causes of acquired sensorineural hearing loss is presbycusis, which, like I said earlier, is just getting older. Noise-induced, which could be working in a factory for so many years, or if you go out shooting a gun, so many times you only hold it over that one shoulder. Meniere's disease, which is also, like I said earlier, the fluid in the ear. Ototoxicity, which is when you take a medicine that can impact your hearing and taking it over and over and over again, it can greatly impact your hearing. Different infections can also impact your hearing, such as meningitis, otitis media, which is water in your ear, or a fluid in your ear, viral infections, and then also head trauma. So any type of large impact to your head can definitely impact the different anatomy in your ear. So different causes of congenital sensorineural hearing loss. So this is the type that you're born with. 60% of that is genetic, so it comes directly from your parents, and 40% is environmental. So GJB2 is a type of gene that makes a protein called connexin 26, and this transfers the potassium ions between the cells, which is found in the cochlea. So any different defects in this gene can lead to this congenital sensorineural hearing loss, and which is the most common found in congenital hearing loss. Genetic factors that can cause sensorineural hearing loss are autosomal dominant hearing loss, and this is when one parent carries the dominant gene and passes it to the child. So in this case, the child would have a 50% chance of acquiring hearing loss. There's also the autosomal recessive hearing loss, in which both parents carry a recessive gene, and in this case, the child will have a 25% chance of getting the hearing loss. And then there's the X-linked hearing loss, in which the mother carries a recessive trait on the sex chromosome, and she can pass it to the males but not the females, and they also have a 25% of acquiring hearing loss. So other factors that could just cause sensorineural hearing loss are measles, HPV. If the child is born very prematurely, this can also contribute to it. If the mother has diabetes and toxemia during pregnancy, so if the mother is taking different types of medications that can contribute to the ototoxicity, can pass it on to the child's hearing loss, and lack of oxygen going to the child.
I'm going to begin by talking about diagnosis and testing of hearing loss. Diagnosing a hearing loss is mostly used by the audiogram, which is a test conducted by an audiologist to determine the severity and type of hearing loss. In order to acquire an audiogram, an audiologist may sit with a patient, and the patient may either face the opposite way or sit in another room, and the audiologist will use a machine in which the patient is using headphones, and if they hear the sound in the headphones, then they will raise the hand on the side they hear it in. If they hear a tone in their right ear, they'll raise their right hand. If they hear a tone in their left ear, they'll raise their left hand. And then this produces an audiogram And on an audiogram, you can tell if someone has mild, moderate, moderately severe, severe, or profound hearing loss. You can also tell if the hearing loss is conductive, sensorineural, or mixed, which is basically kind of if it's on the inner, outer, or middle ear. In our case study, our infant Lily has congenital profound sensorineural hearing loss. Alternative forms of testing other than the audiogram, mostly used on infants, are auditory brainstem response test, which is when electrodes are placed on the patient's head and a stimulus is sent into the ear canal, and then it's recorded how many electrical sound waves are produced by the auditory nerve in reaction to the stimuli. So basically how much of the stimuli it absorbs and then sends to the brain. And then there's also an automated autoacoustic emissions test, which is when a microphone is placed in the ear canal and sound waves are sent to the cochlea, and then the sound produced by the hair cells in the cochlea are recorded. Like I said, these are usually used for infants because infants can't produce audiograms in a way that if they have headphones on their head, they can't raise their hand for an audiologist. So they have to use tests like these where they don't need to react. Other ways of finding hearing loss besides audiograms or the alternative are behavior techniques, such as the visual reinforcement audiometry. And an audiologist will give a child a distraction, and if the patient looks towards the sound when it is played, then they will be rewarded with a positive visual reinforcement. For example, in our audiology class, we watched a video where an audiologist was playing a game. I think they were doing a puzzle with a child. And then, on the other side of the room, a sound was emitted, and if the child looked towards the sound, then they were given a positive visual reinforcement, such as a monkey dancing or something that a child would love to see, so that they knew that when they heard the sound, they had to look towards it, so then they would get the positive reinforcement. And then when they wanted the child to look back, they would have the puzzle or the distraction, so they weren't constantly looking at the noise. And this is mostly for children who can't focus easily and can't sit there and raise their hand and focus for a long time for an audiogram. Here is an example of an audiogram, and on this audiogram is sensorineural hearing loss, which is what we're focusing on. And this might look like an audiogram that our case study child might have. And as you can see, air and bone are touching in this audiogram. Now I'm going to talk about treatment of hearing loss. Surprisingly, less than 25% of people who have hearing loss use hearing aids, as the ASHA website states. And hearing aids are designed to help people with mild to severe hearing loss. So for example, maybe if they have hearing loss on the outer or inner part of their ear. And contrary to popular belief, hearing aids do not cure hearing loss, they only amplify sound. So it's a microphone or a speaker that you can put in your ear, and then it in turn takes in the sound and produces it louder to your eardrum. One type of hearing aids are ear inserts. These are designed to be inserted into the ear canal and can have manual or automatic volume controls. There is many options, such as putting it behind the ear. It can go behind the ear and then an insert go directly into the ear canal. And then there can be ones that are not on the outside of the not behind the ear. They can be inserted into the ear canal, but you can still see them if you glance at someone's ear. And then there's also ones that are completely hidden inside the ear canal, which are very tiny, and you can put them far in. And there's manual controls more recently. So if, let's say, there's a lot of loud noise, the hearing aid can automatically kind of lower the sound so it doesn't hurt the patient's ear. Or there can be, let's say, everyone's whispering. It can amplify that sound louder and turn up the volume so that the patient can hear it better. Or there's, not many people use this just because automatic is easier, but you can have manual volume controls where, let's say, you're on the couch and and an older man doesn't want to hear his wife yelling at him. You can lower the volume. These are mostly used for mild to moderate hearing loss, and they're used to accommodate mostly conductive and mixed hearing losses, like I said, which is usually on the outer or inner ear, outer or middle ear. Next are cochlear implants, which are very popular for people with sensorineural hearing loss. They're used to accommodate severe sensorineural hearing loss resulting from damage to the nerve cells in the cochlea. They're surgically implanted into the inner ear with parts in the outer ear, usually behind the pinna on the skull. And how they work is they will take in the sound waves, and the sound waves will then vibrate the cochlea and the cochlear nerve, and that will send electrical signals to the brain. So they completely don't even use the outer or middle ear. They don't need to use the eardrum. The sounds go directly to the cochlea, and that in turn vibrates the cochlear nerve and goes directly to the brain. Another way to help with hearing loss is early intervention. This isn't something, of course, that you physically put in your ear. Early intervention and insertion increases the chance of better results in auditory skills. So whether hearing loss was present before they developed language skills is also a factor. They're less likely to delay speech and language development. So when a child is born, immediately all hospitals have to do a hearing test on them. And the earlier you catch a hearing loss, the easier it is to grow and develop and have a regular life. So if you immediately get them with speech therapy and an audiologist and a cochlear implant, they will develop more typically, instead of, let's say, not testing them at all, and then in a year they suddenly can't hear and they have trouble learning to talk, trouble just interacting with people in general because they can't hear. IDEA, Individuals with Disabilities Education Act, states that children with hearing problems will receive free early intervention treatment from birth to age 3. So it's almost mandatory that when you're born, a child receives a hearing test, because hearing is so important to early development that they need to know right away. If it's identified before 6 months, they're more likely to have average development similar to their peers. So like I said, if you intervene as early as possible and you get a cochlear implant in there, you get a speech and language pathologist, and you get an audiologist working with them, then they're more likely to develop typically, because their hearing will be so much better and they'll have someone teaching them how to adjust to that hearing loss.
So in our case study, we had a little girl, a little infant named Lily, and when she was born, she did not pass any of her hearing tests, and they made an appointment for her to come back and see a doctor. I think it was like 10 weeks, and the parents missed the doctor's appointment. They just didn't show up, they didn't contact, nothing, and 6 months down the road, they realized the child was not developing like a normal 6-month-old should. They could tell she wasn't, responding to different noises in the household, so they decided to contact the doctor, and they set up an appointment with an audiologist, and Lily was born with congenital profound sensorineural hearing loss, so she basically couldn't hear. So they went through different testing for her. She went through an OAE, and it was absent. They did not find, there was no response in either ear. She went through ABR testing, just like the OAE, there was no response in either ear. Her tympanometry was normal, so her middle ear was moving, all the different anatomy was moving correctly, and how it should be as in a normal child, but her autoacoustic reflex was not, there was no response in that as well. And when everything is absent except the tympanometry test, that goes to show that it is sensorineural hearing loss. So the intervention for Lily, it was a non-syndromic hearing loss, which means there was no other problems with her when she was born. Hearing loss was the only problem she had. So they did give her hearing aids initially, and they did follow-up testing to make sure she was a good candidate for cochlear implants. And by the time she was a year old, she did receive the cochlear implants. They also provided her with a speech-language pathologist to do auditory and language stimulation, which would help her progress like a normal hearing child. And by the time she was a year old and getting used to those cochlear implants and working with the SLP, she was on the right track as if a normal hearing child would be. And so that's our PowerPoint presentation. And here are our resources. And